So I have no financial disclosures related to this presentation, and the objectives of what we're going to try to do in the next 30 minutes is, number one, talk about the most common complications after transplant. So you got tons of information about rejection and so forth, and when you talk about transplant nephrologists, that's kind of one of the main things that, they think about. But I'm going to show you what's actually more important in the long term and things that we are missing. Second, talk a lot about the underlying mechanisms of some of the complications that we're going to see in our transplant patients, and talk about transplant-specific treatments. Things that are different when you compare the general population or even your CKD population with the transplant patients you may be seeing in the clinic or in the hospital. And I'm going to start with a question. So this is a 45-year-old gentleman who has polycystic kidney disease, and he received a living donor transplant 2 years prior. So whenever you're seeing a transplant patient, the timing of the transplant is key, okay? So 2 years, you got to start thinking about other comorbidities if you're comparing to, say, 1 week or 1 month. He was evaluated in clinic and has the following question: what is the most likely cause of death in a patient like me? So let's see, we have A, B, C, D, E here. Let's see if Dr. Javier Alfonso from Miami and Alejandro Meras from Mexico. So if you guys can just scream out what would be your alternative? D, cardiovascular disease. Anybody else? I'm sorry? Cardiovascular D as well, correct. So in the majority of patients, cardiovascular disease is going to be the leading cause of death. There's an exception. So a lot of our patients, they're known diabetic. They may have a higher risk of infection and malignancy compared to cardiovascular disease. So you got to take that into account whenever you're seeing. But the reason why cardiovascular disease is so high, and does transplant actually fix the cardiovascular disease that we see in our end-stage renal disease? And I think the best graph that I can show you is this one. So on this graph, we have the mortality, cardiovascular mortality on the y-axis, and we have the general population here in red, okay? As we get older, which is the x-axis here, our cardiovascular mortality increases. So if you're end-stage renal disease, you're the blue here on the top. So your mortality is extremely high, and even for the younger patients, the relative mortality is much higher. If you get a transplant, you correct some of that, but you don't go back to general population. It's significantly still higher than the general population, and we're going to talk about what are the main risk factors that drive this difference. So on one side, we have the traditional cardiovascular risk factors, the ones we all kind of read about, the Framingham score and so forth: hypertension, hyperlipidemia, some glucose intolerance, diabetes, advanced age, smoking, and so forth. However, when you look at transplant patients and you try to predict their cardiovascular mortality by just those traditional risk factors, that doesn't work, okay? The reason why that doesn't work is because these patients have additional risk factors that actually play even a more important role in the development of cardiovascular disease. So what are those? So number one, poor allograft function. So if you think about this, some of our kidneys, develop rejection, or they have a really prolonged ischemic time, or they come from donors that have a lot of disease, to start with. So poor allograft function puts them at much higher risk of cardiovascular disease than if you were able to correct completely their kidney function back to normal. Number two is a prolonged time on dialysis prior to transplantation. As you increase the number of months, years you're on dialysis after transplantation, we know we have a burden of cardiovascular disease on the endothelium in the heart, and that's not reversible. We won't fix that, okay? We're able to correct going forward, but we cannot fix a lot of those changes. And along those lines of cardiovascular complications and endothelial changes, there is the component of bone mineral disorders that happens in a lot of our patients as they develop advanced kidney disease that lead to the artery calcifications and other complications that put a lot of overload in the heart. So the last thing is something that it's overlooked, but I think it's very, very important, which is called cardiovascular reserve. So frequently when we get an end-stage renal disease patient, we want to evaluate them for transplant, we do a cardiac stress test and say, we want to see if they have any reversible ischemia to suggest that they're going to have a myocardial infarction afterwards. To tell you the truth, it's not that helpful, this test, okay? A lot of our patients are going to have negative, and we have cardiovascular events, and some of them will have positive, go through a cardiac cath and end up showing that, there is significant disease, but it's diffuse disease and it's hard to intervene. But one thing that you can actually extract from those stress tests is actually the cardiovascular reserve. So if they do a true exercise test, so they ask to walk and so forth, and if they're unable to achieve a heart rate, they go into the pharmacological, you can actually tell how much actually effort and they're able to do. And the effort and the amount of activity, the METs, what we call, when you do the stress test, that they're able to achieve is going to determine their mortality. And it's a much, much better predictor than any of the other factors in isolation. So I think whenever you look at that, evaluate the METs as being important. So compared to the other extreme, if you have a patient come in with a wheelchair to get evaluated by transplant, we know that their mortality is extremely high. I don't even have to put on a calculator, okay? But this is something it takes into account as one of the factors whenever we're evaluating those patients, as you probably have seen before. The second aspect about cardiovascular disease is that it's a heterogeneous disease, okay? You have on one side the classic kind of myocardial infarction, okay? So coronary artery disease leading to clots, leading to adynamic walls and so forth. And on the other side, you have all this kind of cardiomyopathy or heart failure that's unrelated to just single vessel disease or coronary artery disease. And we know from our transplant population that they are susceptible to both. And sometimes you're doing interventions that may prevent forming, say, a lipid plaque on the patient. However, he still may be at risk of cardiovascular disease just from the cardiomyopathy and some of the capillary rarification that occurs and the arrhythmias and so forth that may happen. So one of the key components that I think in transplant is different than the general population and even CKD is that many of the immune suppressive drugs that we're going to be using are going to exacerbate risk factors for cardiovascular disease. And here I'm listing the main ones that we use. And as you can see, the CNIs, they can cause hypertension, they can cause nephrotoxicity, they can cause dyslipidemia, they can cause hyperglycemia. So suddenly now we are adding additional factors that may exacerbate that. And I think we have to aggressively manage some of these complications in order to improve our long-term outcome, in particular patient outcome. So let me go to our second question. So this is a 58-year-old Hispanic male with end-stage renal disease from membrane proliferative GN who received a deceased transplant 2 years prior. His post-op course was uncomplicated. He's currently on tacrolimus, mycophenolate, and prednisone. His body mass index is 29. His exam is unremarkable. He was noted to have, though, on a fasting serum glucose of 120 on a routine clinic visit. Which one of the following is the most appropriate next step in management? So we get convert from tacrolimus to cyclosporin, stop prednisone, lose weight with diet and exercise, start metformin, or start insulin therapy. And let's see, Dr. Cunha from Portugal and Dr. Madini from Montreal. You guys can pick from A, B, C, D, E. C, we got C here. Our second one, no? Let's see, Dr. Ramos from Bay City. C, all right. All right, you guys, this is one of the most important things that we got to focus post-transplantation. So weight gain occurs in about 40 to 50% of our patients post-transplant and is a major issue. And why is it an issue? Because hyperglycemia or glucose intolerance is extremely common in our transplant population. So this is a study, very interesting, 114 patients. They went to transplant, they didn't have diabetes prior to transplantation, and 1 year after they assess through a glucose tolerance test what was their rate of diabetes as well as impaired glucose. And as you can see here, 1 in 4 patients develop diabetes after transplantation, okay? And not only that, 50%, almost 50% of them had glucose intolerance, all right? So the issue about glucose management after transplant is critical. It's critical also because it's associated with a higher rate of graft survival, a lower rate of graft survival, and a lower rate of patient survival, okay? And these are the relative risks, either graft failure, death sensor, as well as death. And not only that, it's kind of a spectrum. A spectrum in the sense that if you develop diabetes after transplant, then your risk of cardiovascular events is much higher. However, even if you you have just impaired glucose, fasting glucose. So you're not on the criteria of true diabetes, but your cardiovascular risk is significantly increased compared to normal fasting glucose. So we have to be very attentive to this population in particular. What's interesting about it also is that we have those traditional risk factors for diabetes, say a family history of diabetes, a non-white race such as this patient that we just presented, Hispanic, African American, advanced age, male gender. But then we have the transplant-specific risk factors, which include immune suppressions that we were talking about, steroids. All right. Alarm. Should we? Okay, so let's wait for the signal evacuation. We'll see. So immune suppression. So all of them may have influence on the glucose metabolism, and we'll show you exactly how. Weight gain after transplant, such as this patient, is critical as a risk factor. And then certain viral infections. And somehow the board also likes a lot of this, and a lot of the questions that you may do are related to this. So HCV and CMV are associated with a higher rate of development of diabetes post-transplant. So just to put together why these patients develop such a glucose defect in the metabolism. So one, you have an increase in hepatic gluconeogenesis, okay? So your liver is producing more glucose. Second, you have a reduction in insulin secretion, and I'll show you exactly how this occurs. And third, you have a decrease in insulin sensitivity. That's where kind of some of the weight gains and as well as the steroid use kind of happens. So let's just kind of isolate and look into individual factors. And the only last thing I want to point out is that hemoglobin A1C is not a good marker to be used early after transplantation, okay? Because your hemoglobin is kind of changing. Your EPO production is much higher on the graft, so the amount and the stability. Oh my God.
The hotel fire alarm has been activated. Our management staff is currently reviewing the situation and will momentarily advise.
Okay, we'll continue. Sorry about that. So hemoglobin A1C, not good to be used in the first 6 months after transplant. If things are stable after the 6 months, creatinine is stable, then it becomes a good marker. So we have to use either fasting glucose or a glucose tolerance test to assess that. So this is the cyanide effect of insulin secretion that I wanted you to kind of remember. And visually, I'm a very visual guy, so this is beta cells that have been cultured either with just median or with cyclosporin or with tacrolimus. And the black stuff is the insulin staining in these beta cells. So both cyclosporin and in particular tacrolimus inhibits insulin secretion from the beta pancreatic cells. So this is one of the main mechanisms how they cause diabetes. And what's nice here to see is there's a trial that they reduce the tacrolimus and they look at insulin production. And this is what happens once you reduce the tacrolimus. Your insulin production goes significantly higher. So this is important because if we're managing our patients, we're looking at the rejection, that's very important, but we got to think about other comorbidities and complications, and we got to try to minimize that in the long term. The other aspect that's very interesting about this is that they also compare steroid withdrawal before and after and measure the insulin sensitivity as well as the insulin secretion. As you can see, steroids do not affect insulin secretion, but if you look at insulin sensitivity, it increases when you take off patients out of steroids, okay? So this is how steroids kind of ended up affecting a lot of the metabolism of glucose.
Our management staff is currently reviewing the situation.
Okay, we'll keep going. So what about all the trials that have done now that they withdraw steroids? Do they have a lower risk of developing diabetes in the long term? So there's a big change or a big difference between comparing studies in the 1990s with studies, say, in the 2000s, okay? Because in the 1990s, we used to use much more glucose than we're currently using now. So now most of our patients, if we're putting in maintenance, they're on 5 milligrams. That's it, top, okay? Before, you've seen a lot of patients on 10, 20 alternating days and so forth. So this is a trial where they look prospectively up to 5 years on patients on steroids, and the majority of them are on 5 milligrams. And when we look at this, there was no significant difference in the development of diabetes, okay? This tells us that, even with all the excitements about steroid withdrawal, we got to take into account that if you use a very low dose, it may not have such a dramatic effect in the development of diabetes. So this goes to the question that we were trying to answer, okay? So how do we approach some glucose intolerance in our transplant patients after transplant? I think number one is if the patient is overweight, this is how we're gonna get it down, okay? And you have to show them, okay, that they're gonna shorten their life by a few years if they continue to gain weight and if they don't get their blood glucose under better control. And then sequentially, oh my God, this is gonna kill me. Sorry. All right, second, if you have still glucose intolerance, okay, we go for the oral hypoglycemic agents, okay? So the oral hypoglycemic agents of choice starts with the metformin, okay? The FDA just approved that we're able to use up to a GFR above 30, okay? Which before, people were always worried about using a GFR between 30 and 45. Now the FDA allows us to use it, but monitoring with caution for the lactic acidosis. But metformin for sure is one of the best agents. And then sequentially, the insulin therapy will be the last one. And always think about decreasing the immune suppression if possible, including lower dose of steroids and the CNI. So from diabetes, we're gonna move on to some other complications. I'll do a quick board key points just for us to refresh what we just spoke. So death with a functioning allograft is the major cause of long-term graft loss. So our patients are not losing the graft, but they're actually dying with a functioning graft. So this is why the importance of this. Mortality is cardiovascular infection, malignancy in sequence. The transplant-specific cardiovascular risk factors, in particular, time on dialysis pre-transplant, poor allograft function, and metabolic disorders associated with immune suppressive drugs are important. Transplant-associated hyperglycemia affects the majority of our patients post-transplant. We have to be looking at the other factors, including immune suppression, weight gain, and viral infections, and last of all, metformin is the first agent to be used, especially if GFR is above 30 in patients that have persistent hyperglycemia. All right, so from that we'll move to hypertension. Hypertension is also very, very common post-transplantation. It affects more than 65% of patients in this cohort 1 year after transplant that involved 3,500 patients, okay? What's important also is that the control of blood pressure may determine the ultimate outcome of the graft. And as you can see here, if you're able to get your blood pressure under better control, your outcomes are much better. Even if you're able to control after the first year, your outcomes are better than someone who had poorly controlled hypertension up to the third year. So this is definitely something we should be keeping track. And just to give you numbers of how blood pressure can affect mortality and cardiovascular disease, a 20 millimeter increase in mercury of systolic blood pressure in kidney transplant patients raises your risk of cardiovascular disease in 32% and your mortality in 13%. Okay, so this is clearly something we must aim. So similar to what we were discussing about glucose metabolism, hypertension has a strong component of the immune suppressive drugs driving this blood pressure up. Calcineurin inhibitors can cause hypertension by two mechanisms: vasoconstriction and stimulation of the sodium chloride cotransporter in the kidney tubules. Okay, so you have both constriction as well as increase in the volume of the blood because of that sodium chloride reabsorption. Steroids, in particular in higher doses, can also cause sodium retention and lead to that. And there are other factors that also participate in exacerbating hypertension post-transplant, including the poor allograft function. And one of the red flags is kind of a sudden worsening in blood pressure, pre-existing hypertension or obesity, as we've seen on the other kind of Hispanic patient, and donor factors. And this is very interesting, you know, if you think back, because if you have a patient who is donating a kidney to the recipient, and he has a history of hypertension, control one drug, or he has a family history of hypertension, the recipient will have a higher chance of developing hypertension post-transplant, okay? So there's some factors intrinsic to the kidney, being those hormonal or, you know, in the metabolism or handling of sodium chloride, that's intrinsic that may determine if you're gonna develop hypertension or have a higher sensitivity to high salt diets and so forth post-transplantation. To show you the effect of CNI and how withdrawal of a CNI may improve blood pressure, this is a study where they compare MMF with a group that stayed on CNI, and this is the improvement in blood pressure. Almost 10 millimeters of mercury improvement in both systolic and diastolic blood pressure when you take the patients off CNI. We know that that's not the perfect practice because CNI are very, very good drugs, but it's a very good concept to at least kind of keep in mind about the effects of CNI in hypertension. And this is clearly the effect of the vasoconstriction that you see in the glomeruli, the decrease in GFR that your glomeruli feel once you have the CNI exposure into those. All right, so let's go to our third question. So this is a 55-year-old female with end-stage renal disease from FSGS, so focal segmental glomerulosclerosis, who was on dialysis for 5 years and now has received a leaving-related transplant 3 months ago. Post-op course had a little complications such as wound infection and a central line thrombosis. And now she comes in with acute dyspnea and hypertension for 3 days, okay? So medications, she's on triple immune suppression, as you can see on the bottom, and she was, prior to this, only one blood pressure medication, metoprolol. This is the exam, so remarkable for a systolic blood pressure 195/70. On a prior visit, she was 100/60. She has crackles in the lungs, and she has trace edema on the lower extremities. Her creatinine is 1.5 from a baseline 1.3, so not that much elevated, but the chest x-ray shows some pulmonary edema. The Prograf trough level, so the tacrolimus trough level was 8. So the question is, so what is the most appropriate next step? Should you reduce the Prograf? Should you stop the prednisone? Should you obtain a Doppler ultrasound? Should you get methanephrin, or should you get a renin-aldosterone ratio? So let's get Dr. Souza from Brazil and Dr. Vélez from Denver. Get an ultrasound, okay. Anybody else? No? Okay. So that's correct answer. So why do we get an ultrasound? So renal artery stenosis is one of the most common kind of early complications post-transplantation that can lead to a very refractory hypertension. That occurs within the first 3 months to 2 years after transplant. So he's exactly in that period. And this is an example of a Doppler of a renal artery. This is the velocity of the blood flow through the renal artery. And as you can measure here, it's 33 centimeters per second, which is extremely high. So this patient then underwent an angiogram. The angiogram shows this is stenosis right here. And you see that with the angioplasty that was done, you're able to open this up significantly and improve the blood flow throughout the kidney. And this is more common in deceased donors than living donors, okay? And one thing that's very important is that the diagnosis is very operator dependent when we're talking about the Doppler ultrasound. So you have to go and review with the radiologists exactly the imaging, because sometimes the way they angle the probe, they may miss it, or they may overcall it in cases where it's absent. And always the confirmation needs the angiogram in order to make sure this is actually true. So the treatment of choice is angioplasty, and the intervention has a success rate of over 94% with only a 10% recurrence, so it's extremely effective overall. So what's the management of our patients post-transplant, so not considering the renal artery stenosis? So first of all, there's no data to suggest the exact kind of goal of blood pressure. So we kind of extrapolate from what we know from other studies. So for sure it should be below 140/90 and maybe even lower in some diabetic patients. We always have to consider reducing the CNI, because I showed you that significant effect of the CNI on blood pressure. And some patients may be more sensitive than others to the vasoconstrictive effect and the hypertensive effect, and for sure we see this. So the first choice of agent for controlling blood pressure after transplant is always a calcium channel blocker, such as amlodipine, okay? You can use as an alternative the hydrochlorothiazide, or even a beta blocker, such as labetalol or metoprolol, depending on the heart rate, depending on other comorbidities. But in general, the amlodipine is the number one. What about ACE inhibitors and ARBs? So we all are very used to use those in CKD patients. The problem about using those early after transplant is that you get into the trouble of seeing a rise in creatinine and not knowing if this is a rejection or is just kind of the vasoconstrictive or some of the reduction in GFR that occurs with the ACE and ARBs. There's also a significant effect about hyperkalemia, that when you're using CNI and the ACE inhibitor, this potentiates a lot and becomes sometimes a limitation to use it. So there's no data to suggest that using ACE inhibitor or ARB improves graft or patient survival. And there was this trial that came out just last year at the Lancet Diabetic Endocrinology, not in a nephrology journal, so a lot of people didn't see, but they compared ramipril with with a placebo here and look over time at the cumulative patient survival, and the event rate was exactly the same, okay? So it's a small study, there are 100 patients on each arm, but at least there's no strong evidence to suggest that we should be pushing our patients with the ACE inhibitors with some of the limitations in regards to GFR as well as the hyperkalemia. All right, so one more question. This is a 60-year-old female who underwent a kidney transplant 3 years before and is now coming for her yearly follow-up. Creatinine is stable at 1.5 on triple immune suppression. Other medications include amlodipine and aspirin. Routine labs show that there's hypercholesterolemia with a total cholesterol of 250, LDL of 150, HDL of 30, and normal triglycerides. So what is the best treatment option for this patient's hypercholesterolemia? I'll let you kind of read it through it, and then I'll pick 2 more names. So we'll do Dr. Tarbox from San Antonio, and Dr. Rao from Scotch Plains. Are they here? Okay. No? All right. Okay. Then you can shout out your answer. C? Simvastatin? C as well? All right. That's very good. However, there's an issue. There's a lot of drug-drug interactions when we're talking about the use of statins in transplant patients because of the interaction with P450, all right? So fluvastatin is one of the safest statins to be used because they are not metabolized by P450. So there is now a FDA kind of black box about using cyclosporin with simvastatin, okay? That's completely blocked out. We shouldn't be using. If we're gonna use a statin, we should never use a maximum dose of statins, okay? We should kind of top at the 50% kind of mark, all right? And this is just some of the, let me pull it up here. So the FDA warning came out in 2011, okay? And this also brings the question that you guys probably discussed when we were looking into the immune suppressive drugs, that there are drugs that affect P450 that we should be aware of. And other drugs include like antifungals such as the azoles or macrolide antibiotics or even calcium channel blockers. The immune suppressive drugs, again, play an important role in exacerbating this lipidemia, including cyclosporin, tacrolimus, steroids, and mTOR inhibitors that has a predominant effect on triglycerides. Okay, there has been a very good randomized trial looking at treatment of lipids, elevated lipids post-transplant, and looking at outcomes. However, it only showed a trend towards lower mortality when they looked in the fluvastatin treatment group compared to no treatment. But they did some post-doc analysis afterwards, and they showed that there was a subset of patients that developed a significant benefit, and those were the transplant patients that had risk for coronary artery events, such as myocardial infarction. So those patients benefited the most of the statin treatment, and we tend to put all our patients on statins. This is a graph just kind of showing the safest statins to use in transplant: fluvastatin, pravastatin, and pitavastatin. Well, because of that kind of black box, we've been kind of staying away from simvastatin, or we're kind of using it lower dose. And if you want to use a more powerful statin because the cholesterol is too out of control, atorvastatin is the agent of choice. Rosuvastatin was recently compared, is one of the newer kind of anti-hyperlipidemic agents to atorvastatin in the PLANET trial that was published in Lancet Diabetes in 2015. However, it suggested that atorvastatin was actually better in the renal protection. So atorvastatin, at least on my kind of a list, it becomes the #1 choice whenever we're using that. Okay, one more question. We have a 75-year-old Caucasian male, okay, with polycystic kidney disease that got a kidney transplant 20 years before. He was doing fantastic, but suddenly in the past few months, he started losing weight and having night sweats. He is currently on triple immune suppression, tacrolimus 4 twice a day, mycophenolate 1 gram twice a day, and prednisone 5, and amlodipine 10 milligrams. So for someone who didn't have a lot of complications, this is quite of a high of immune suppression, as Dr. Azi just showed you. So on exam, it's pretty much unremarkable, but he has the palpable polycystic kidneys that you can feel on both sides, and he also has some new femoral lymph nodes that can be palpable, a little bit enlarged. Creatinine is at baseline, 1.8, and the question is, which one of the following is the most appropriate next step? So we have kidney biopsy, a PET scan, a chest X-ray, an abdominal X-ray, or an abdominal MRI. And let's see, who do we get here? Dr. Owen from North Carolina, and we'll get Dr. Atenitis from Brockton. Are they here? Raise hands. No? One more. Dr. Benini from Brazil. No? Anybody want to just shout out? So there's... All right, so we got everything here. Okay, so that's good. That's always good when there's a little bit discrepancy. So what we're most worried about this patient is malignancy, okay? So the best way to kind of follow this, especially if he has the femoral lymph nodes there, is to do a PET scan, because the PET scan is going to really be able to tell if there's anything that's kind of uptaking, highly metabolic, that's outside of the usual kind of structures that are hypermetabolic in the body. So in this case, you see kind of the really kind of hypermetabolic state here. And this patient had what we call a PTLD, which is a post-transplant lymphoproliferative disorder. So this is one of the most common cancers post-transplantation. It has a kind of a bimodal presentation, either early after transplant or really late after transplant. And there's a correlation to the presence of EBV infection that kind of drives the process. There are other infections that are important to know: skin cancer, kidney cancer, and Kaposi sarcoma, which is related to the herpes 8 virus. The pathogenesis involves three factors that affects our transplant populations. One is the repair mechanisms that are affected whenever we are immune suppressive drugs. So you have sudden damage to the DNA, such as UV light, smoking, and suddenly we are unable to repair that. Second is the oncogenic viral infection. So we are more prone to viral infections, and certain viruses have factors that promote the growth of tumors. And this is the case of EBV, for example, or HHV8. And third of all, we're learning more and more about immune surveillance. So our immune system is usually able to shut off cells that start proliferating out of control. However, when you're immune suppressed, some of these shut off mechanisms are affected. So this is the three kind of main roles of how this may occur. So PTLD, we discussed a little bit about the bimodal presentation, the high association with EBV infection, and the risks include high immune suppression, co-infection with CMV, and the presence of EBV negative serologies prior to transplantation. Treatment involves kind of a bimodal approach as well. So you reduce the immune suppression, as well as you try to use some lymphoma targeted therapies, including chemotherapy, as well as anti-CD20 therapy to deplete cells. These are some of the other cancers that are common after transplantation that are related to infectious agents. In addition to the ones we spoke, human papillomavirus and Merkel cell are additional cancers. And there are certain cancers that are not higher risk post-transplant, such as breast and prostate cancers. And this is interesting because there's something behind the immune suppressive role in certain cancers that's unknown at this point. mTOR inhibitors tend to be the only agent that seems to be protective in regards to cancer. You saw this already. This is just a picture showing a resolution of a Kaposi sarcoma in a patient that received that. And the mechanisms that this occurs is that they are anti-proliferative and anti-angiogenic, in addition to their immune suppressive effect. So in certain cases, they are extremely helpful in patients with recurrent skin cancer, for example. Main side effects are preventing this to become kind of one of the main drugs that we use in the clinic, and also because they're not as powerful as immune suppressive drugs in general. And the third thing is that they're limiting factors, including the poor kidney function, that may prevent us from using this agent, okay? Just focus on the picture here. These assess recurrence of skin cancers after converting to mTOR inhibitors. So this is the sirolimus that they use, and we are able to reduce the recurrence of skin cancers once we convert it to them. So there's no solid studies on other cancers about this, but this is definitely considering high-risk patients. This is board review key points from what we just discussed. So I won't go over it since we just came on. And the last two slides, one is about drug-drug interaction. You got to be aware of this, not just for the board, but when you're managing your patients. Antacids and calcium supplements may affect mycophenolate, so this is something very concerning we got to be aware of. Diarrhea can increase the absorption of tacrolimus and raises the level. So if you have someone with kidney dysfunction, with diarrhea, it's not only dehydration. You got to measure the tacrolimus level, and also always think about agents that may affect P450 because these play a crucial role, antifungals, macrolides, and certain calcium channel blockers such as diltiazem and verapamil. And last of all, I think closing to what Dr. Ozzie discussed last time, you gotta make sure that you think about multiple factors when you're adjusting immune suppression. So you're thinking about the risk of rejection, and not only that, but you also think about all the other comorbidities that may be important. There's some references here. They asked me about some of the pictures that I have. This is from the kidney transplant iBook that I put together a few years back. I was frustrated with, either handbooks of transplantation that I couldn't read, or the pictures were so awful, or the vast, data that's present for up to date that's really hard to kind of get a grasp on. Immunologists constantly changing, so we put together some, easy ways to understand the immune system with kind of nice graphs and processes of how does the immune system causes different forms of rejection, how the pathology occurs, how does that correlate, and some videos, especially with anti-HLA testing that's extremely complex. You can read like 10 pages on a book and never understand what it is, and sometimes videos are helpful in this. Review questions that go over some important topics and test your knowledge, and then some problem-based approaches, which is exactly what we feel in the clinic. You have a case scenario and you want to kind of go over the answers and some of the issues, and some hyperlinks to other important papers that you may be worth kind of doing.